I'm extremely happy, honored to have my mentor and friend, Dr. William Jennings, professor of surgery, University of Oklahoma, who is very well known for his work in vascular access, the proximal radial artery fistula, pioneer of fistula first, and many other things. How are you, Dr. Jennings?
I'm fine. Appreciate the chance to talk.
What is your thought process when you're seeing a patient and you want to create a fistula? How do you process things?
Well, I think that statement is reasonable, but there's plenty of exceptions that you just have to consider. For instance, in a older patient that has a lot of solar energy in the forearms and the skin is very poor quality, you might consider an upper arm fistula to be a more reasonable choice because they're going to have trouble with cannulation. If you have someone that has challenged blood flow in the radial artery at the wrist, you're probably looking at many interventions, if not failure, and you might consider a more proximal fistula. As you said, the proximal radial or proximal ulnar artery might be a better choice. You want to avoid early failure. If you have poor choices in the non-dominant arm, and you have a lovely opportunity to make a successful fistula in the opposite arm, I think that you'd avoid the likely failure in that arm, and you'd choose the one where you're going to have success. There's a lot of anguish and problems associated with repeated interventions and repeated operations for fistula failure. So I'd choose the arm that's likely to succeed.
So for you, if I understand correctly, the most important thing is to have the best chances to have a successful fistula creation, not necessarily accept failure initially and then try something later if it doesn't work.
That has been my practice. And of course, each patient, you have a discussion with them and you discuss this question and the possibility. I think a moderate or low flow fistula that's going to last for years, even in the dominant arm, is not going to be a problem for most patients. So that's correct. I'd choose success over dominant or non-dominant arm. The word ultrasound brings up the question of how to use the ultrasound. I think most people agree that ultrasound mapping is a very valuable tool. It's okay to have an ultrasound mapping report done prior to seeing the patient. There's no problem with that, but I would encourage everybody that your success rate is going to be much higher when you become comfortable with ultrasounding the arm of your patient. I do that routinely as I'm introducing myself and talking to the patient and taking history. I put a tourniquet on the arm. I do that examination in a warm environment so that you don't have venous spasm, and and get my own examination of the entire venous and arterial imaging in the arm. That does not take a long time, and it is easily incorporated into your office visit. You're going to find opportunities and avoid a fistula that is otherwise destined to fail, rather than just take a few measurements in a report and make a decision.
And do you measure the diameter of the vein, or just with experience, you're just mapping up and down and you get an image of what's going to be doable or not?
I think when you see a marginal vein, you might actually freeze the ultrasound image and measure that to help you make your decision. Sweeping up and down the arm gives you a good feel for whether there's any intermittent small areas of vein thickening or obstruction or narrowing that might have been missed in the ultrasound lab by a technician who's smart and reasonable, but yet is not experienced in surgical procedures.
Do you search for any specific threshold of diameter of artery size and vein size?
Classically, minimum sizes are 2 millimeter in the artery and 2.5 in the vein. Certainly, you and I have both operated on children where we use smaller vessels that are pristine, and those will work also well. There might be a time where you'd uh, see that the vein is 2 millimeters and compliant, easily distendable by putting a tourniquet in place in a warm environment, and you're willing to use that. Uh, you might be willing to do a very distal fistula, like a snuff box, in a patient that is pre-dialysis, and you have months ahead of you that you have time for this fistula finally mature and be usable, or even need a revision. So it's not one size fits all.
Okay. And how about the artery? Are you measuring the size of the artery, or it's more the quality, calcifications, radial dominant, ulnar dominant?
Both of all of that. So I think if, as you and I both know, I'm kind of preaching to the choir here, talking to you about all this, Alex, but you're kind to ask. Uh, we could start talking about the arterial supply. There are patients you're going to encounter that are radial artery dominant, or even those that are completely dependent on their radial artery flow into the hand. And you might feel or not feel a good ulnar pulse, but it's certainly worth looking with your ultrasound quickly to see if the ulnar artery is tiny or even occluded, and the entire hand depends on flow through the radial artery. At that point, you'd want to use proximal ulnar for inflow, but somehow avoid a fistula uh, with a dominant radial artery that's likely to lead to an ischemic hand. So that's the arterial concept. Ultrasound is going to show you there's going to be patients that your ultrasound will show that if you made the fistula just a few centimeters more proximal from the wrist, you're going to find there's a large side branch comes in and the vein is twice as big at that point. And by just moving a little bit more proximally for your radiocephalic fistula, you're going to have a much better success rate because you're going to incorporate that site where the vein is much larger. And so it just becomes very much determined by your own examination ultrasound that might not be apparent in a simple ultrasound report.
Do you think that if you check with ultrasound the ulnar artery and the radial artery and you see they're both normal, do you have to do the Allen's test?
I will often put do a modified Allen's where I can augment and listen to flow in the palm, in the arch, and occlude the ulnar artery with my other hand, and or occlude the radial artery, and see if the flow is interrupted or problematic by interrupting one of the by occluding the arteries at the wrist. So I do that just so routinely. It just takes a few seconds to do it. It's probably not important if you're happy that the arteries are normal to examination. So I think that's not a key element.
And what about the distance between the vein and the artery and the decision of where you're going to do your incision? Is this something that you take under consideration?
Uh-huh. I'm only smiling because these are questions that you could yourself answer very nicely, but I'll go ahead. Uh, a good example that's objective is when the main vein at the wrist is the dorsal vein at the wrist, really far away from the radial artery. Uh, uh, some surgeons have thought that the way to handle that is to do a radar procedure where you divide the radial artery distally, swing it up, and have it become the conduit that moves and do not disturb or change the position of the dorsal vein at the wrist. I very infrequently use that, but on occasion it's a useful thing. Uh, I think the key in general to that solution, when the vein and artery are not simply adjacent is to elevate the radial artery. I don't divide it, but simply divide the small, tiny twig arterial branches by mobilizing a lot of the radial artery. If you try to tie those, you're going to avulse them off the artery and make it a problem to have to oversew those with fine sutures. So I bovie those 2 or 3 millimeters away from the artery, elevate the artery so that it comes up, and then that allows an easy transition for the anastomosis. I often use Dr. Chenoy's onlay patch technique at that point because the artery and the vein can be made adjacent, and you just do a side-to-side anastomosis without really mobilizing much of the vein. You will always have to mobilize some, but minimize that. I think you offer more chance for torsion or twisting or a technical mistake by swinging the target outflow vein all the way down deep into the location of a non-elevated radial artery.
Do you think that by mobilizing the vein too much, you are increasing the risk of technical problems, or there may be something physiological with the vascularization of the vein and inducing biochemical or biological factors that are inducing stenosis in the vein?
That's a great question, and it's a two-part question. The first one, do you increase the risk of a technical misadventure? Absolutely. Without knowing it or without recognizing it, you can accidentally get a little spiral in the vein, or where the vein now has to go from superficial to deep by rotating it deep into where the radial artery is. You get a little kink or a twist. So absolutely technical. And what you say, the more you mobilize of the vein, there may be injury. I don't think that's a proven or unproven thing. We understand that shear stress changes in that segment of the transposed part of the vein increase, and I think you increase that by mobilization of the vein. So the answer to that, the first part is absolutely. The answer to your second part is probably.
And what about uh, distal basilic veins here? Let's say you don't have a radiocephalic option, but you have good radial artery, good ulnar artery, and you have a beautiful distal vein here.
Mm-hmm.
Would you do this, or you would go for a proximal radiocephalic?
So that differs in Europe and the United States. It seems surgeons in Europe are more aware of considering the distal basilic vein. I've transposed that vein many times. It's kind of a bit of a nuisance to have to mobilize the vein, hold the arm up during the surgery where you make, I would use skip incisions to mobilize the vein and tunnel it to the radial artery so it's only easily cannulatable in the forearm. I know you wrote a nice, interesting paper about just simply doing a non-transposed forearm basilic vein fistula, and you could cannulate into the upper arm when necessary. I think in Europe, surgeons, maybe not frequently, but often, allow the nurses to cannulate a non-transposed basilic vein in the forearm. In the United States, the experience of the cannulating team makes that essentially impossible.
First of all, the difference between the basilic of the forearm and the arm, at least the basilic of the forearm, it's under the skin, it's not under the fascia. It's in the arm, at least for the proximal part of the arm, you definitely have to do it because
Mm-hmm.
it's under the fascia, the nerve is there, the punctures are more painful, you may stick the
Right.
artery accidentally, etc. Definitely more cumbersome because there is nothing very solid behind, so the vein is moving a lot, the position is kind of weird. So it is rare that you will see a patient with a forearm basilic fistula and everybody's going to be happy and there's no
Right.
problems at all. So it's, although the vein is there commonly, you will not see very commonly this fistula.
Right. And I think the experience of the dialysis units in the United States makes that super difficult to convince them to start cannulating a non-transposed forearm basilic. So probably that's not very practical.
And something that perhaps some of our listeners are not aware is that in Europe, most places have nurses that
Yes,
are puncturing fistulas, while in the US, I believe you're having technicians with short training periods.
100%. Absolutely. And years ago, you would have a cannulation expert in every unit, and that's disappeared in the United States. So cannulation is a real persistent problem.
Yeah, yeah. And I'm guessing this is for financial reasons, for reducing the cost for hiring trained people in the units.
That's my
Or
understanding. You know, a kind of a collateral answer to that would be an example of how difficult it is to get ultrasound guided cannulation established in the units in the United States, even though we've looked at it for 20 years, it simply is not common. I think it's more common and exists more often in Europe.
when did you, let's say, discover or decided to go to the proximal radial artery territory and create this beautiful technique that I learned from you?
Oh, it's a good memory. It's hard to believe, but my life as a surgeon existed as a resident before we had CAT scans available, and my goodness, well before we had any kind of practical ultrasound in the OR. Finally, many decades ago, the neurosurgeons at the hospital I worked at the most got an ultrasound machine. It was huge, like as big as a rhinoceros, and once I wheeled that into the OR to do a fistula, everything changed.
Uh-huh.
That you could see that doing a simple uh, fistula at the wrist was 100% fail because the veins were occluded from IVs, and then that led me to make an decision and recognize that the uh, proximal radial artery was easily mobilized. You didn't take the risk of, or you dramatically decreased the risk of an ischemic hand by avoiding the brachial artery. And it was plenty big enough to make a fistula in most patients. And you had the deep communicating vein and all these other venous outflow choices. And ultrasound was able to show us what veins were going to work in general, what veins were going to fail, and so that was a really an eye-opening opportunity.
So I'm guessing, if I'm understanding correctly, you were basically discovering this new rhinoceros-like huge machine and playing with the machine in the OR and observing
Oh,
the arteries and the veins, and it suddenly hit you that the radial artery is there and the perforating vein is just next to it, and you just have to go there and connect them because they're just next to each other.
yeah, same with the median cephalic or the median cubital. You could look at those before you did your surgery, uh, and your operation. You already had your operation planned. You weren't exploring and putting probes up veins to see if they're open or not. You knew at that point, and so it changed uh, an operation where you were uncertain and you were trying to pass probes to decide if a vein is open and adequate for a fistula. You simply knew at that point where your incision needed to be to find this proper anatomy, and it simplified everything and made the operation tremendously quicker and more
And
successful.
how did you decide to go out of your comfort zone as a surgeon and doing what you're regularly doing in search of trying to do something different? Because I'm guessing it was uncomfortable for you. People were like, what is he doing with this huge machine that it's probably nonsense? And I mean, we're surgeons. Why do we need this machine here? What was the process? Can you explain a bit?
Oh, I think in years, many decades ago, there was no anxiety or stress from trying a new technique. And of all the different maneuvers we do, ultrasound is the most benign and non-threatening imaging you can imagine. So it was the ultrasound was in our hospital. The neurosurgeons almost never used it, and so I just routinely would wheel it in, scan the arm for a few minutes, and you could see what was going to work and what was going to fail. Not only what was going to work, but you could see what was going to result in a failed fistula, and I think that was a big change for me. So there was nothing stressful or problematic about using the ultrasound on an arm. Very easy. And it extends in when we started using it for intraoperative abdominal procedures, looking at finding a liver tumor or a pancreatic islet cell tumor that wasn't very big. It changed everything, made everything so much easier.
Yeah. I'm guessing it must have been a revolutionary moment when the ultrasound was introduced in clinical practice. It was like you having
Yes.
a crystal ball
Yes.
or like looking through patients' anatomy and knowing what's inside before taking the scalpel in your hands and start searching.
And just like our TVs change and get better every year or two, and our computers get better every year or two, ultrasound has become incredibly valuable and accurate, and the imaging is just wonderful. And the imaging was not so good at those times, the early times, but it was good enough to make a huge difference.
Would you ever create a brachiocephalic or a brachiobasilic fistula?
Oh, sure. Absolutely. There's going to be times when all of us are going to find that there's simply uh, it's not common, but there's going to be times where the mechanics of the outflow vein simply won't reach the proximal radial or proximal ulnar artery. That's the most common reason I would use the brachial artery. Uh, there will be rarely times where maybe the ulnar comes off low and you can't get to it technically reliably, and the proximal radial, even up to the juncture with the brachial artery, is poor, very tiny, and you need to use the brachial artery. So the only warning I would say about that is you really want to, and there's some good data about this, you really want to make the opening in the brachial artery uh, 4 millimeters or less. And it is dependent on the size of the brachial artery. If you have an elderly lady, as an example, with a very small brachial artery, I think making a brachial artery fistula is more at risk for having an ischemic hand. If you have a 3 millimeter brachial artery and you make a 4 millimeter opening in the brachial artery, I think you're at significant risk of having distal ischemia. And that might change your outlook, that you say, gosh, in this difficult situation, I need to have arterial inflow from the axillary artery go up proximal to the deep brachial takeoff.
So how would you do that?
Well, again, now we're talking about very uncommon situations where we've already said that there's no arterial inflow opportunity at the wrist. For whatever reason, there's no opportunity to make a fistula in the cubital fossa because of either vein length or other opportunities. Then you could use a basilic vein or a cephalic vein or a piece of PTFE for your inflow from the axillary vessel down to where your venous outflow anastomosis is going to be made. And of course, that venous outflow choice is going to be determined by your ultrasound examination and imaging to see what vein is big enough to mature. And there's a few patients that, as much as I hate to put foreign body in people's arms, there's going to be an occasional patient where you probably use a graft, but I think those are really pretty rare.
So if you use a graft for this particular patient that you have no option, but you have, let's say, arterial inflow is poor and you will use a graft, you would go high in the axillary artery before the profunda here?
Yes, I think that's the key, is that you come off where the artery is larger, and you're going to make a 4 millimeter anastomosis on a 5 millimeter or 6 millimeter artery that's normal in appearance and flow, and you're going to be able to not. You won't see a steel phenomena.
And do you take a tapered graft? Like,
It's very attractive, and I think taper grafts came out 20 years ago with the idea that if you used a tapered graft and the smaller part on the artery, you're going to avoid steel. That has, in other studies, that was never proven to be so. So I think you tailor the graft for the size of the vessels, and so I do use the tapered graft. That's the one our hospital's always stocked, and so I think if it's not been shown that lowers the risk of hand ischemia, but going proximal does avoid hand ischemia. I mean, what's your practice? Is that the same thing you do?
that's exactly what I'm doing. But I have to say that my impression was that when I'm using the tapered graft, now this is going to be very technical and I'm going to try to describe well what I'm trying to explain. If you just, let's say the tapered graft is 4 millimeters to 7 millimeters.
Yes.
What I realize is that if you open the artery just 4 millimeters and you just go end to side and you do a tiny anastomosis with the very end of the graft, you tend to have occlusions. So I decided to taper the graft at the 4 millimeter side. So I have a large anastomosis. Then the graft will taper again to 4 or 5 millimeter, which will be the limiting factor, and then open again.
100%.
Yes.
100%. That's exactly what I would suggest, and agree completely that you don't need to make a tiny little 4 millimeter anastomosis to this graft that's now going to actually have to turn. You need to taper it, and you can make a larger anastomosis without risk of hand ischemia when you're proximal to the deep brachial artery.
And the other advantage of this is if you have to do an angioplasty or thrombectomy or whatever, the angle that the graft is coming into the artery is more favorable for your Fogarty to go inside. Because if you're a 90% degree, then you
Right.
will find it difficult to get a Fogarty inside or whatever.
Right. And that 90% angle that you just referenced offers the opportunity for a kink, even
Yes.
though when you're closing the wound, it looks fine, but it just wants to kink at that place. So I think you need to do exactly the procedure you're talking about, an angled,
The king
flared
when
anastomosis.
the king when it turns to go into the tunnel.
Yes.
Yes. Yeah.
Yeah.
And how about the anastomosis to the vein? Are you tapering and making a huge anastomosis, or are you going to go end to end?
I would probably taper end to side if I have the opportunity. There are mechanical situations where you need to do an end to end, but I would taper to a long anastomosis, and that's when, if you develop narrowing, that's the likely spot, is where the graft hooks into the vein, is the more likely spot where they finally become narrow. So I make that a generous anastomosis.
What do you think about? I've been doing this technique, and I believe it was published, and there was also a graft, a hybrid graft from Gore with half graft and half covered stent. Well, instead of suturing the anastomosis between the graft and the vein, you're actually putting a covered stent inside the vein. So basically, you avoid the anastomosis, and you have like an end-to-end inside telescope.
John Ross has talked about that for 10 or 15 years, I think. And I would guess he's done more, or at least overseen more of those procedures than anyone. I have never done one of those, and you may have comments about it because you've probably used that technique. I think it's where you have difficult arterial exposure because of just arteriosclerotic disease, that maybe that's a handy way being able to establish inflow or outflow. You know, he uses that where he would do the venous outflow anastomosis well up into the axilla, farther than he would want to expose. So I think Dr. Ross has written about that and probably is the leading proponent of that technique. You tell me, is that something you use?
Yeah, I use it. I use it very commonly because um, I find that under ultrasound you can choose the right vein and puncture it easily and avoid the dissection and the suturing. So technically, it's easier. I have the impression that patients are doing better because essentially almost all the grafts that I'm doing, they will get a stenosis after the graft to vein
Right,
anastomosis.
right.
And I don't know if it's technical or, there are so many theories out there, the surgical dissection, the difference in compliance between the graft and vein, many different things. But I use it more and more, and I think there is probably something there that makes it better.
I think that
Um,
would be really good to have it doesn't even have to be a prospective randomized trial, just to report. Uh, if you look at a lot of articles about grafts in general, after 2 years, you have primary patency of about 28%. And after 2 years, you have cumulative patency of 50 to 60%. And so if you can beat those in these more challenging patients you're talking about, I think that'd be a valuable contribution. So if you have enough numbers, that would be interesting to see how long they last.
I was anticipating that the discussion with Dr. Jennings is going to be quite long because we're both very passionate about this subject. Therefore, this second episode will be uploaded as part one and part two. I hope you enjoyed this first episode where we explored many issues regarding distal fistulas, how to deal with patients with problematic arterial inflow, the use of grafts, and some technical specificities about the grafts. In the second episode, please join us, and we will talk with Dr. Jennings about uh, basilic elevations and transpositions and more technical details about the proximal radial artery fistula. And also, she will speak about the fistula first and some of the missions that she did with Bridge of Life to create fistulas in some countries in Latin America. So please subscribe to the channel, like and share, and join us for the second part of this episode with Dr. Jennings in 2 weeks. Thank you.